Osteoporosis medications are an important component of effective bone health protection strategy. Bisphosphonate medications increase bone density, thereby helping prevent fractures. Within 6 months, when taken in conjunction with vitamin D and calcium, these medications can reduce fractures of the hip, spine, rib, wrist, and long bones by 40 to 60%. There are several bisphosphonate therapy options available. Oral bisphosphonates can be taken weekly or monthly. Intravenous bisphosphonates are infused once a year. Nurses must carefully follow specific administration procedures for oral bisphosphonates to maximize absorption and minimize side effects such as nausea, abdominal pain, and loose bowel movements. Bisphosphonates must be given first thing in the morning, at least half an hour before breakfast. They must be taken with a glass of water only, and must be taken alone with no other medications. Bisphosphonates should not be crushed and should be given only to residents who can swallow effectively. After receiving bisphosphonates, the resident should remain sitting for at least half an hour. Vitamin D and calcium should be given to the resident later, with lunch or supper.
Okay, so you gotta stay sitting down. You can't lie down or anything, okay? Just gotta go down to digest properly.
What are the pharmacological therapy recommendations for older adults at high risk for fracture? We calculated effects of benefits and harms at 1 year or more, and thereafter these recommendations apply to older persons with life expectancy greater than 1 year. To develop these recommendations, we placed high value on issues that are prevalent among older persons, which may make it difficult to safely administer these medications. We also considered immediate risk of fractures and consequences of falls and fractures, for example, loss of mobility, greater risk of mortality, and increased pain. For high-risk residents, we recommend alendronate 70 milligrams weekly, risedronate 35 milligrams weekly, or 150 milligrams monthly as first-line therapies. These medications are not to be crushed. They are to be administered in the morning on an empty stomach, and only if the resident can remain upright for 30 minutes after administration. Risedronate DR, however, can be taken immediately after breakfast and is not required to be taken first thing in the morning or on an empty stomach. Contraindications to alendronate and risedronate include avoiding these medications when there is severe renal or kidney issues, defined as a creatinine clearance less than 30. For those at high risk of fractures and who cannot swallow or have difficulty taking oral medications, we recommend zoledronic acid and denosumab as first-line therapies. These recommendations apply particularly to residents who have difficulty taking oral medications due to dysphagia, inability to sit up for 30 minutes, and have cognitive impairment or intolerance. While denosumab can be prescribed to residents with renal impairment, they are at higher risk of developing hypocalcemia. It's recommended that monitoring of the calcium levels and consideration to referral of a specialist be made. Zoledronic acid should not be used in individuals with severe renal impairment. For residents at high risk of fracture, we suggest teriparatide. Although the benefits of teriparatide, in particular on vertebral fractures, probably outweigh harms of treatment, the cost of therapy restricts its access, and there may be a higher burden due to the daily injections. For high-risk residents, we suggest that raloxifene and etidronate not be used. In summary, the goal of these recommendations are to improve the lives of seniors residing in long-term care. First, determine the risk of fracture on admission, asking the questions reviewed previously. Nutrition, calcium and vitamin D supplementation should be considered first. Exercise, hip protectors, and interventions to prevent falls and fracture are also recommended. Consider pharmacological therapy for residents at high risk of fracture. For access to the recommendations and other tools and resources, please visit the following websites: Osteoporosis Canada, Canadian Medical Association Journal, and the Jarrah Centre.